Hello, I'm Andrew Gase, your host for today's presentation. I want to welcome you back to the Brain Matters webinar series. Our topic today is ICP Individualization and Prediction. We are honored today to have as our featured speaker, Dr. Christos Lazaridis, a neurointensivist and associate professor in the departments of neurology and neurosurgery at the University of Chicago. His main interests focus on neuromonitoring and management of acutely brain-injured patients, as well as in shared decision-making and ethics in neurocritical care. Dr. Lazaridis will speak about intracranial pressure in TBI. Please type in your questions during the talk. We will now go to Dr. Lazaridis in Chicago.
Hi, Andrew. Thank you very much for the introduction. And I want to thank Moberg ICU Solutions for giving me the opportunity to share some thoughts and ideas about intracranial pressure monitoring, management, and some research projects in relation to ICP and secondary brain injury prediction. I assume my sound is all right, so I'm going to share my screen here. Andrew, can you see the slide?
Looking good.
Okay, all right. Thank you. So this will hopefully not take more than 40 minutes, and I'm more than happy to take any questions if there are any at the end, either through the chat or the Q&A boxes. All right, so my disclosures, I do have some funding from the Institute of Translational Medicine at the University of Chicago for a pilot study on ICP prediction. I have participated in the Boost 2 and currently in Boost 3, and I don't have any other financial disclosures. So today I'm going to be addressing three topics, and I'll spend about 10-15 minutes for each. First, I want to offer some conceptual points about these ideas of precision medicine versus heuristics, and maybe suggest that we somehow need a little bit of both. Then I'm going to talk about patient-specific intracranial pressure, and then finally about prediction of secondary brain injury crisis, prediction of intracranial hypertension. Okay, let me start with a conceptual point here about how maybe we should think about physiologic thresholds for treatment. So I would like to suggest that these are constructs. These are physiologic constructs that involve clinical problem-solving heuristics. What is a heuristic? Heuristics are strategies that ignore information to make decisions faster, more frugally, and hopefully more accurately. And they are basically rules of thumb that may be very useful in particularly complex situations where it's either impossible to have all the information, or it's extremely hard to combine them in a successful way. And so rules of thumb may be particularly useful. So how does that relate to intracranial hypertension and ICP after TBI? Let me offer a little bit of a review here, and I'm going to do this in a little bit of a cartoonish way, but this is a bird's eye view of how to think about the current map of how people think about intracranial pressure after TBI. So I'm going to start with the first group, which I will call the foundationalists. And by the way, I have to say the disclaimer here is that I found myself and my colleagues belonging in multiple of these categories at different times. So foundationalists would follow loyally the Brain Trauma Foundation guidelines. I think this is the most common paradigm in North America and Europe currently. And we all know the most recent iteration of the guidelines were in 2017, and the thresholds for treatment, the suggested thresholds for treatment were set at an ICP less than 22 and a CPP goal of 60 to 70. Out of this, more recently, the Seattle International Consensus Conference has suggested a protocol based on this goal, a management protocol that was missing from the actual Brain Trauma Foundation guidelines. The second group in the middle I will call skeptics. And skeptics bring certain objections and charges to this and critiques to this foundationalist approach. One of them, and I'll discuss this a little bit more further on, but one of them is this problem of ecological fallacy, which refers to a potential mistake we are making when we are taking an epidemiologic threshold and try to apply it to individual patients. And the problem magnifies the more complex and more heterogeneous a disease is. And so this applies fairly well for severe traumatic brain injury. There is also concern about, in the last 2 decades, a large randomized clinical trials in this disease that have not been particularly encouraging and supporting, if you like, of the very traditional paradigm of the, following the Brain Trauma Foundation approach. Out of this, and I don't really mean to say that this is a skeptical approach. I'm just putting here the ICE protocol, the imaging and clinical exam protocol that evolved out of the BEST TRIP trial, just as a protocol that does not use ICP as a heuristic. It uses imaging and clinical exam. Then finally, on the other side is a group that I would call physiologists. And the idea here is that there are multiple other tools that we can use at the bedside, so-called multimodality monitors, to understand individual patient physiology and also be able to follow it dynamically. And so that's a way to individualize treatment at the bedside and try to respect heterogeneity, both in terms of the characteristics of the host, of the patient, but also the changing pathophysiology. And so there are different tools here, anywhere from transcranial Doppler to electrocorticography, NIRS. And there are platforms like Moberg and ICM Plus that can help in getting this high resolution data at the bedside, and also deriving some more complex parameters that can help understand the pathophysiology at the time. Out of this, so we had some early success with the BOOST-2, the phase 2 trial. I should say that the CBIC algorithm also includes a protocol that has partial brain tissue oxygenation as part of the management strategy. And then, if you like, a further group that belongs in this category, precisionist, right? The idea that we can look at optimal CPP, and very specifically look patient to patient and from time to time at metabolic and energy crisis. And so this entire group is where you would start talking about precision medicine, individualization. Now, these 3 groups map fairly well in terms of how they think, how they use the idea of a threshold. And so within the classic paradigm of Brain Trauma Foundation, here you can speak of one and fixed protocol. This is, I'm oversimplifying a little bit, since the Brain Trauma Foundation also recommends that there should take into account patient characteristics and time from injury to adjust the ICP threshold. For the ICE protocol, there's no ICP threshold since ICP is not monitored. And then finally, the physiologist precision medicine group, you can argue that there would be many thresholds. Okay, let me offer some points in terms of critiques towards this one fixed generic threshold approach. So this is where, this is a paper from the Cambridge group and Sorrentino, where the latest iteration of the guidelines, this is where the numbers came from, the ICP of 22 and the 60 to 70 range for CPP. And the point to make is that they also look at pressure reactivity index thresholds here, but the methodology they used is they use serial chi-squares for different thresholds to find the best discriminator for mortality and outcome. And so this is an epidemiologic threshold out of a specific database from Addenbrooks. Okay, so what is the problem with taking those numbers and applying them to individual patients? In terms of imaging, one can talk about endophenotypes. This is a typical picture that goes over classic imaging characteristics of different types of closed traumatic brain injury. And then, of course, with further imaging, MRI imaging, one can pick abnormalities that could be predictive or consequential in terms of outcome, but may not be associated with intracranial hypertension, for example. So variability in terms of imaging. A side note here is that this is an example of penetrating brain injury patients, and these are from recent publications from our group at the University of Chicago. We are seeing, in fact, a preponderance of penetrating gunshot wound-related brain injuries rather than closed. Maybe I would say something like 60-40, which is a little bit unique, I think, in comparison to most other trauma centers. But the point to make is that this potentially could be a different type of disease, right? We are finding different incidents and a lot higher incidence of direct vascular injury. And we have also seen a potentially coagulopathic phenotype of penetrating brain injury that is associated with particularly very high mortality and poor outcomes. This is a review by Stockeri et al. In Lancet Neurology, a very nice review of many aspects of epidemiology and management of severe traumatic brain injury. And this figure, again, goes over this concept that when you look at specific types of injury and you divide them parenchymal versus vascular, the risk of intracranial hypertension, risk of mortality, and risk of disability is very different. And so the argument becomes a critique, the idea that if you group all of these types of injury and you assign a single number of ICP or CPP or any other physiologic threshold for that matter, you would be ignoring this wide variability in clinical trajectories here. And then a busy slide, intentionally try to make it busy. This is I talked about imaging variability, about clinical trajectory variability. But then if you start looking with multimodality monitors at the actual pathophysiology, both regional and global, you get this very complex picture, right? And that's where I think this physiologist approach comes into play. The argument is that you really have to look at this individual physiologic variables to understand exactly what is the tissue pathology at the time of the individual patient. This, of course, cuts the other way as well. This may be a very complex process. Our understanding of these mechanisms, I would dare say, is preliminary. And so there may be a degree of complexity here that is hard to handle. And this connects with the idea of heuristics, right? Heuristics may take this very complex picture and try to give you some simple solutions that, although not perfect and not accurate in terms of pathophysiology, may be successful enough, may get you the outcomes you need. And so this slide serves both as a critique of the traditional approach, but it also says something about complexity that may be over our ability to understand and handle at the bedside. Okay, so let me summarize some criticisms of the traditional paradigm of the Brain Trauma Foundation, of the generic fixed threshold. So I mentioned the ecological fallacy that epidemiologic thresholds are not intervention, patient-specific intervention thresholds. There is wide heterogeneity ignoring, and that refers to structural heterogeneity, temporal, and also host-specific variability. There is pathophysiology ignoring when we don't take into account all of these other features of the secondary brain injury cascades, like the adequacy of cerebral blood flow, the relationships and the balance between oxygen delivery and utilization, and then the quality of cellular metabolism and mitochondrial function. The other criticism here is that we tend to think of those violations of threshold in a unidimensional fashion. So we say ICP over 20 or 22 or 25, and then we act. However, what is missed there is this idea of a dose of an insult, where you have to think both about the violation of a certain threshold and also the amount of time that this was applied for. And I have a couple of more slides to talk about dose of ICP. Then finally, there is a problem of a false dichotomy, this idea that below the threshold of 22, we are within safe physiology. And once we exceed that number, we are in the space of unsafe physiology. And so we have to act. And I think this is a fallacious way to think about pathophysiology in this disease. Finally, I think very importantly, there is an unknown benefit to risk ratio. So we are striving to achieve a certain ICP threshold, and we are increasing tiers of treatment, and this comes with a cost. And so this balance between achieving a certain ICP number at a given time at a given patient and the systemic costs of the treatments we're applying is not very well described and understood. Okay, let me move and discuss quickly this paper by Lonnie et al. It was published about a year ago, and I'm not going to go into details. This was discussed elegantly by Dr. Longi in a previous webinar in this Moberg series. But it's an impressive work, and the more I read, the more I learn. The more times I read this paper, the more I learn. But basically, what the investigators did, they had about 60 to 70 patients with severe TBI. This is in Addenbrooks, and they did 15 oxygen PET under stable conditions. These patients were monitored with ICP, and they were managed according to the local protocol. And also, a lot of them had also partial brain tissue oxygen tension monitors. Then they also had about 20 controls. So they looked at ischemic brain volume. They quantified that by using a certain definition of oxygen extraction fraction that the group has validated in previous studies. And so what are the results here? So one is that the other interesting thing about the paper is that they looked at patients in a very acute stage all the way up to about 10 days, if I'm not mistaken. So what they found using this OEF threshold is that ischemia is common early, something that I think was expected, something known. The more interesting and concerning finding is that ischemia can be detectable up to 10 days after TBI. It is possible without intracranial hypertension, something that has been shown before. There are patients with low ICP who yet may experience metabolic and energy crisis and tissue injury. Interestingly, there was not a great relationship between ischemic brain volume as defined in this study by oxygen extraction fraction and either jugular venous bulb oxygenation or brain tissue oximetry. Importantly, and this links back to some of the comments I made earlier, substantial pathophysiological heterogeneity, not only in between patients, but within the same patient. So different regions of interest, for example, they would show a physiology of hyperemia versus other areas that would be ischemic. Question this idea of using local monitors of physiology, and also the correlation between local and global monitors. And again, exactly that ischemia and hyperemia may commonly coexist within the same patient. Okay, one more slide. This is one of the figures from the paper showing you on the x-axis, you have partial brain tissue oxygen tension. And then on the y-axis, you have ischemic brain volume as defined by PET. And I think you can notice in the with PbO2 less than 20, which is the conventional threshold, you can see plenty of what one would consider normal OEF. And so you in fact can see a wide spread and a poor correlation between PbO2 and OEF by PET, suggesting a few things. One of them is that, again, putting into question using a focal monitor to generalize pathophysiologic thresholds for the entire brain in focal and global monitoring. And then the other point to make is that potentially for patients who have low OEF, there may be other mechanisms beyond macrovascular ischemia that may be operative. So mechanisms that preclude the increase of OEF, for example, diffusion oxygen barriers. Okay, and summarize again and going over merits and drawbacks of these three approaches. And I'm thinking of all these three approaches as simply different heuristics. So for the Brain Trauma Foundation, the dominant paradigm, the merits of the approach is that in terms of observational data, when the protocol is, when clinicians adhere to the protocol, mortality reduction has been documented. It's a concise protocol and relatively easy to follow. And I think the CBIC recommendations are very helpful in that regards. And it's also long-standing and established. I think a lot of ICUs and neurotrauma ICUs have experience with using the tiered interventions in accordance with BTF. What are the drawbacks? I talked about this already. There is no patient specificity. The thresholds are not dynamic, and we do not really account for other major mechanisms of secondary brain injury. What about the imaging and clinical exam protocol? So this is a studied alternative within the bounds of the BEST TRIP trial. And one would argue that in the absence, if ICP monitoring is not available, that is the only studied evidence-based protocol to use. Drawbacks here is that, at least from the BEST TRIP, there was an increased intensity and duration of brain-specific treatments. High clinical vigilance is required and potentially frequent imaging. And then there is a question about the external validity of the study because of the specific conditions and where it was performed. So it may not apply in other ICU settings with different types of capabilities. Finally, multimodality monitoring. So here we are looking at potentially several other variables that are relevant beyond ICP and CPP. We sample more secondary brain injury pathways, and it allows for dynamic adjustments. What are the drawbacks? Is intense and complex, right? And the places that have availability and expertise to do this well are not very many. There are no definitive protocols for use. This is, of course, in terms of at least partial brain tissue oxygenation, we will have data from BOOST 3, and the CBIC protocol does offer guidance. And then finally, and really, really importantly, we do not have robust clinical outcome data here. Okay, let me move on to the second topic, which is patient-specific thresholds of intracranial pressure. And here I just want to discuss a study that I was involved with under the mentorship of Marek Czosnika at Addenbrooks. And so the premise, the hypothesis, I guess, for this study was to try to find a way to look at patient-specific ICP. And the factor we thought to look at was pressure reactivity index. So we said that we're going to calculate the burden of disease, so the burden of intracranial hypertension, according to three different thresholds. The threshold of 20, threshold of 25, and a patient-specific threshold according to the pressure reactivity index. And again, this study was done before the last iteration of Brain Trauma Foundation guidelines, and that's why we went with the ICP threshold of 20. And this is an example of how to identify this patient-specific threshold. We defined it as the ICP at which that corresponds to a transition point between intact pressure reactivity index, meaning 0 and below, versus a transition to a constantly elevated PRX over 0.2. And that's how we defined this patient-specific threshold. There were about 300 patients in the database. This was done manually, basically graphing out the entire ICU history of each patient and trying to find these transition points. I should say that this was only possible in 2/3 of patients. And it's an interesting point for discussion why in this other 1/3, you really cannot identify transition points. This depicts how the dose of ICP was calculated. It's a standard method of looking at the trapezoidal method of looking area under the curve. You set the threshold. For example, here you see for a threshold of 20, and you calculate the cumulative burden of episodes of ICP over that given threshold, multiplied by the time that this occurred. And so using this, then we derive for every single patient 3 different doses. This is what we found in terms of the spread of this pressure reactivity weighted ICP with a median of 24. Important to remember that this is a treated cohort of patients. They are all receiving neurointensive care with defined goals for ICP and CPP. And this just shows you simply that if you look at this database and these 2/3 of the patients that were analyzed, you can get patient-specific or pressure reactivity weighted ICP thresholds anywhere from 10 to 40 in most of these patients. Interestingly to say, so what we end up finding is that when you try to correlate these patient-specific ICPs as a dose, how do they correlate with mortality? We found that they were more predictive than the doses calculated via the threshold, the classic threshold of 20 and the threshold of 25. And this is despite the fact that if you look at the absolute burden, the absolute dose of D20 over the DPRX, the absolute dose for a threshold of 20 was higher. Parenthesis here, this is a very nice way to visualize dose of different insults, dose of ICP. This is a very recent paper by collaboration between the Cambridge and the Leuven groups. And it just shows you in the x-axis, the insult intensity and insult duration in the y-axis. And you see these blue and red colors give you a sense of correlation between a given dose and outcome. And I think ICP dose, CPP dose, these are important metrics that we need to find a way to incorporate into actual management of patients. So fast forward a little bit to 2 months ago, this study was published by Frederick Zeiler and the Cambridge group and Center TBI investigators. And this is a validation of the work we did that I just showed you from the Cambridge database. Significant improvements on this work include that the patient-specific threshold was identified in a semi-automatic computerized way and not manually by graphing out this, the ICU histories of patients. And also I should say this was done about 130 patients in the Center TBI in the high resolution cohort, high resolution data cohort of the Center TBI study. And a very similar result was found here. This is just ROC curves. This is univariate correlations. On the very top here, you see an hourly dose of ICP over 20. This is hourly dose for ICP over 22. And this is hourly dose over the pressure reactivity weighted threshold. And this just simply shows you that there is indeed a signal here suggesting that if you, this patient-specific ICP threshold is a stronger predictor with mortality at least in comparison with this generic threshold derived doses. Okay, so what are some maybe conclusions one can get out of this work, the original work and the validation? One is that the impact of intracranial pressure on clinical outcome is critically linked to the state of cerebrovascular pressure reactivity, and this should probably come without surprise. Pressure-passive conditions add vulnerability in the presence of intracranial hypertension, despite the actual level of ICP. Pressure reactivity is one of the factors that may qualify the association of intracranial hypertension with patient outcomes. And I'm saying one of the factors because you saw the ROC curves have only had modest predictive ability. And it does make sense. There are several other pathophysiologic variables here that do qualify this association of patient outcome and intracranial hypertension. And importantly, in both studies, one thing to say is that these are, again, epidemiologic thresholds. So I'm not suggesting that this is anywhere close of targeting this pressure reactivity weighted ICP. These are, again, epidemiologic thresholds. And so the ecological fallacy I talked about in the beginning applies. But the other point to make is that they are only identifiable in 2/3 of patients. If you do it manually or if you do it in a semi-automatic way, in about 1/3 of patients, you cannot identify the transition point. And this may be related. For example, there are patients on both extremes, patients who may have low ICP throughout their course, or they have intact pressure reactivity, or patients on the other side with intracranial hypertension, who have deranged pressure reactivity for most of their ICU monitoring time. And so a discrete transition point cannot be identified. Let me come to the third topic here I wanted to discuss, which is prediction of secondary brain injury crisis and prediction of intracranial hypertension. This is a graph demonstrating the course from a nice review paper demonstrating it's a relatively typical course of patients who develop refractory intracranial hypertension. About 20% of patients with severe TBI will need tier 2 and above types of treatment for ICP. And you see these discrete events, right? You see these 1 to 7 very clear ICP spikes, some of them plateau waves. And the way we manage this currently, we have this reactive approach, right? We are called at the bedside when a certain threshold is violated, and we start doing things. We start escalating treatments until we can control this episode. So I think it's plausible to suggest that if we have the ability to predict these episodes, and more importantly, to put this prediction to work, meaning to be able to prevent them from happening, then we may decrease the cumulative burden of intracranial hypertension, the cumulative dose of ICP, and potentially improve outcomes. So I think the hypothesis and the aim for a prediction project is straightforward. It's try to find machine learning or statistical methods that can give us an accurate alarm and try to use a preventive treatment algorithm to reduce the number of these episodes. This is a review we not too long ago performed together with Craig Razin and Claudia Robertson in Houston. And we looked at the literature of ICP forecasting and the literature on different prediction studies for ICP and CPP. There are several more current publications, but I think this goes up to something like 2017 or 2018. And you can see the predicted variables. You can see the cohort, the number of patients where these techniques were applied. All of these are, again, retrospective studies, some of them on prospectively collected data. You can see the statistical or machine learning methods that have been applied and the different evaluation metrics for the performance of the prediction algorithms. I want to mention some studies that are particularly important, I think, in this field. The Leuven group has done really innovative, interesting work in this field. A noticeable paper in 2013 by Fabian Giza et al. Then some work that we did in Houston with Dr. Risa Myers, a computer scientist, and Claudia Robertson and Craig Razin, which I'm just going to spend 2 minutes explaining what we did. And then finally, more recent papers. The most recent one, this letter in intensive care medicine, again by the Leuven group, where they took the model that they had developed and they validated it in the high resolution center TBI cohort data. So Dr. Myers, what she did here to classify these episodes, we discussed what kind of episodes we want to predict, and we decided that what would be meaningful and interesting is to try to predict a certain ICP dose. For this study, we defined an ICP crisis as an ICP that exceeded 20 millimeters mercury for more than 15 minutes. And we also looked at partial brain tissue oxygenation crisis episodes, which, to my knowledge, this is the only study that has developed a predictive model for brain tissue hypoxia. And we defined those events as a PbO2 less than 10 for more than 10 minutes. And again, the specific thresholds and timings are not as interesting. You can obviously modify the dose to that you wish to predict. The database, very generously, these data were provided by Claudia Robertson at Bentab, a quite rich database and unique, spanning over 30 years of severe TBI management, included a total of 874 TBI patients. And as typically done in this kind of studies, the cohorts were divided into three groups. The older cohort patients were used for training of different statistical and machine learning models. There was about 370 patients. Then another 108 patients were used for model selection. So one looks at, develops these different models and tests them for performance. And then finally, the best models were used for cross-validation and evaluation in the most recent cohort of patients, which at the time, we had about 260 patients in the period of 2006 and 2013. These are, of course, prospectively collected data, but all of this work is done retrospectively. This is not high resolution data. However, when you have such an extent of a database, there is a lot of data. There were more than 200,000 hours of ICU time, more than 13 million readings. And the signals that were investigated were ICP, PbO2, mean arterial pressure, oxygen saturation, and end-tidal CO2. There was also a smaller cohort, but still sizable, of 242 patients with PbO2 data. And again, the same process was followed with training, model selection, and evaluation cohorts. So what Dr. Myers actually came up to find, which is interesting, is that only 5 features, there were 5 predictive features that account for and provide a very good prediction model. What are those? Those are the time spent in each of 2 states. I'm going to explain this in a minute, which states I mean. The last 2 points in the primary signal of interest, and that applies both to ICP and PbO2, and the time since last crisis. The 2 states, what RISA did is she used a model that was exploiting a hidden Markov model that learns time series and segments them according to 2 states. One, a non-crisis state, so a state of low ICP and relatively stable signal, and then a pre-crisis state where you have the signal actually picking up, the ICP increasing, and it's classified by the algorithm as a pre-crisis algorithm. And so the time a patient spent in either of these 2 states was a predictive feature for this model. How did it perform? It performed quite well. The task we wanted to achieve was prediction 30 minutes ahead of an actual crisis event. And both for ICP and PbO2, the AUC of the model was up to 0.8, 0.9. Actually, performance remains fairly good up to an hour before a crisis event. And again, AUC is not the only metric that one should use to evaluate the performance of a model. You could have a lower AUC, but the model may be clinically still useful. Couple of more comments about the work we're trying to do right now. This is data that we received from the BOOST 2 investigators, and I certainly want to thank them for their generosity and sharing this data. We're trying to apply some of these algorithms in the Boost data because these are high resolution data collected with Moberg. And we want to try to see if we can maintain good predictive performance when we apply the algorithms developed before to this higher frequency ICP and PbO2 data. What we're using here as a surrogate of crisis is, again, the different types of events as were defined in the Boost 2 trial. So we're trying to identify episodes of pure high ICP, type B episodes, pure brain hypoxia type C, and we're also trying to see if we could predict the combined event, meaning intracranial hypertension in the presence of brain tissue hypoxia. However, these events were not as frequent, and so we'll have to see how that works out. But we're almost done with this analysis, and hopefully we can have something soon. I'm going to end with a prediction project that we also have in mind, and we have a little bit of funding to get started with. The idea here is to create a virtual monitor, to create a smart alarm system in order to be able to predict these episodes of high ICP or low PbO2. This is a graph from Craig Razin and Medical Informatics. This is a mock picture. This is actually taken by a predictive algorithm that the group had developed for predicting neonatal cardiac arrest. And this is how, I guess, we would envision having this prediction modeling where you are given a TBI risk index, let's say 30 minutes, an hour before a crisis. You're given a certain forecasting about how probable it is to have a ICP crisis in the next given period of time. And then, of course, the real bet would be to be able to have some kind of a clinical management protocol that is successful in preempting those crises. As a summary, so phase 1 and phase 2 is the things we are attempting, we are trying to build right now at the University of Chicago. So continuous collection of waveforms and data, and establish really a real-time processing of put these algorithms in real-time work. Then we need to assess how these algorithms work in terms of prospective validation. As patients are, again, in a obviously in a non-interventional way, as patients are receiving routine care. And then finally, if that seems successful, then one has to think what kind of a clinical recipe would work in potentially trying to, as I said earlier, preempt those episodes, and with the goal of decreasing the burden of insults. Last slide, just to summarize some of the things I said. So what are our goals? And I will also say what are our heuristic goals here. One is to optimize the tissue, and this refers to brain physiology. We want to avoid brain dysauxia, maintain metabolic viability, and potentially predict and prevent those harmful secondary brain injury cascades. The other very, very important part is obviously managing the entire patient and managing different organ system conflicts. And we have to be aware and cognizant that as we are trying to optimize brain physiology the best way we can, our interventions have potential costs. And these have to be very seriously accounted for. And some lessons from heuristics. One is that less is more. Sometimes, particularly the more complex a situation is, this may be even more applicable. And then there's a concept of ecological rationality, the idea that simply different types of management may apply well in different types of environment. As an example is the ICE protocol where it was tested and developed. 30 seconds just to thank the people that are doing this work. I want to thank my colleagues at the University of Chicago, our neuro-ICU nurses and trainees, Claudia Robertson and Craig Razin from Baylor College of Medicine, who have done the work in the paper I showed you with ICP prediction. And then finally, Marek Czosnika and Peter Smileski for their mentorship and help for the patient-specific ICP work. Thank you very much. I'm more than happy to take questions if there are any. Maybe should I stop sharing, Andrew, and open for questions?
Hi there, everybody. So while you're all typing in your questions, I want to remind you about our newsletter, the Neuroscience Monitor, which will keep you up to date in neuromonitoring. You and your colleagues can sign up anytime at our website. If you have an event or news item related to neuromonitoring and neurocritical care, please send it to us. And don't forget to please get those questions in. It looks like we're already getting a number of them, both in the Q&A and in the chat, Dr. Lazaridis. So we will now go back to you for our Q&A. So get those questions in.
Okay. All right. Thank you very much. There's already a few of them. Let me see if I can try answer some. So there's a question about, is the brain trauma foundation strategy a successful heuristic? Good question. The simple quick answer would be yes, in terms of the idea that I think there is evidence that when the BTF guidelines are adhered to, outcome is better. So it does function as potentially a good number of rules of thumb to decrease mortality. The question is, can we do even better? Richard Moberg is asking if you could pick one monitoring modality that you could magically measure easily and continuously to manage a TBI patient, what would it be? Oh, wow. I may need to think about this. Let me see if I can answer other questions easier. Jose Carnona says another important part of this individualized approach must be the factors of such hypotension and hypoxia. Very much agree with that. And so he's discussing about the impact of hypotension and hypoxia in the outcome of TBI. Agreed. Do you believe that ICP waveform can be used as an indicator? Excellent question. There are several people who are far more experts than me in this question, but yes, I do think that there is a lot of information in the ICP waveform, both in terms of an indirect pressure volume curve or compliance, and also information about the quality of cerebrovascular reactivity. The question is that the techniques to analyze these things are not as widespread. Do you use partial brain tissue oxygen tension to set ICP CPP targets? So we are part of Boost 3, and so we follow that protocol. Are there any patients in the severe TBI subset in which you are not placing or are delayed in placing ICP monitors? If so, are you monitoring for the potential for edema through serial imaging? Excellent question, and I'm embarrassed to say I don't really know how well we do in terms of adhering to Brain Trauma Foundation guidelines, but I would venture to say that there is some clinical management that comes into play. So we may wait, for example, patients who are intoxicated or where imaging may not be as suggestive, we may wait and follow clinical exam. And we certainly use serial imaging. We often do a 4 or 6 hour follow-up head CT in patients with severe TBI. Thank you, Christine. What variables go into the state 1 versus state 2 calculation? I think you are referring to the prediction modeling by Risa Myers. She used a classification machine learning algorithm called autoregressive ordinal regression that basically learns latent states in a time series and segments it accordingly. Do you believe ICP waveform could be an additional information for ICP hypertension prediction? I think we talked about this a little bit earlier. Marek Czosnica, what is the best management protocol aimed at preventing intracranial hypertension? I wish Marek can actually take the mic and tell us here, as he's a pioneer in most of the things I talked about. But yeah, I don't. That's the question. That's why I'm thinking about this in terms of heuristics. That I'm not really sure if there is a best management protocol, and so we need to figure out how to incorporate multimodality monitors, but in a way that is controllable, in a way that bedside providers can actually follow protocols that make sense, and very importantly, keep an eye on the side effects of the things we do. Threshold for PbO2 of 20. We use the Brain Trauma Foundation guidelines for that threshold. Edwin is asking about critical pressure reactivity index, where you would use ICP instead of CPP therapy. Yeah, so this again refers back to the Cambridge work about PRX. I don't think I have another comment. I'm very eagerly waiting to hear the results of the Cogitate trial in terms of optimal CPP. Is there any accounting for the presence of cortical spreading depression in these studies? I think that's what CSD refers to. In the studies that I talked about, not really. It wasn't one of the mechanisms monitored, but there's no question that this is a very relevant mechanism in the pathways of secondary brain injury. Francis Bernard, can you comment on PRX in the setting of craniectomy? And I think there is an issue about the validity of pressure reactivity index in situations of very of high intracranial compliance, meaning when there is a bone flap missing. Ana Rodriguez, how would you balance the advantage given by individualized treatment and the effort, therapeutic intensity required to achieve that? That's a key question, and I don't know the answer, but I'm very concerned of the idea of using multiple monitors where we think we understand what's going on. We target therapies according to these monitors, and again the side effects that they may have. So I think we need more actual prospective hard outcome data, both in terms of functional outcomes, but also in terms of the cost. The ICP Heatmaps that Fabian uses to visualize the safe area of ICP were based on Glasgow Outcome Scale. Do you think this tool could improve if a better TBI endpoint was used, such as the ones developed in Track TBI? Yes, I think that's a good question about the idea that GOS is a crude functional outcome and would certainly welcome more fine-grained ways to look at what happens to patients after their acute care and long-term. Regarding multimodality monitoring, which of them would you consider the minimum, thinking of low-income developing countries? Great question. I think what is mostly available may be transcranial Doppler, and I think it's reasonable to say that if you don't have access to ICP monitoring, that you should in fact follow the ICE protocol as developed in Best Trip. And Angela Mortegui says, what would you recommend first to implement hospital, PbO2 or PRX? I don't know, whatever you can get your hands on, but I think a lot of us are waiting for results from Boost 3 to really understand what the future of PbO2 monitoring may be. Andrew, if I'm running out of time, please just let me know and stop me from blabbering. I'm just going to go over to the chat. Daiwai Olson says there is a fourth tribe. Those of us who are not yet convinced that the variable being reported is representative of the pressure to which some part of the brain is exposed. You might call us measurement scientists. I love that. So I'll make my slide even a little bit busier and include this idea for sure. Jamil Aldalati says, it's an engineer, biomedical engineer, which unfortunately I don't have any expertise on. I think we covered everything else. Andrew, Andrew Kofke says, should ICP thresholds take into account ICP due to arterial hyperemia, venous congestion, and brain edema as an element of individual? Absolutely. And I think Dr. Kofke has actually written recently a very nice review about thinking the etiology of ICP, right? We often group treatments regardless of very specifically looking at etiology. So I definitely agree with the comment. Okay.
Dr. Lazaridis, looks like we got 3 more in the Q&A, and then I think we'll wrap it up.
Okay. Do you have any experience, Dr. Johansson, do you have any experience or knowledge of any studies in using microdialysis as a predictor of intracranial increase in ICP? Great question. The only exposure I had to microdialysis is during a short period I spent at Cambridge, but we don't have it accessible here. And my only limited understanding is through mostly the reading I've done. But it's plausible. It seems very plausible that we need to understand what is the local biochemistry if we're going to optimize relationships between oxygen delivery, utilization, and optimize tissue outcome. Okay. Andrew, I think I'll stop here. I think most of the issues I kind of tried to address.
All right. Well,
and thank you so much, everyone, for attending. There are several people here I can see who are real experts. So thanks again.
Yes, and I will second that. Thank you to you, Dr. Lazaridis. That was a terrific presentation. If people continue to have more questions, feel free to send those in. And thank you to all of our participants for joining us. We hope to see you all on our next webinar.